As you see, the title is different, and we had some conversations back and forth, and we thought that we have the data for NHANES 7.8 and 5.6 publicly available at this time. So we decided to talk about NHANES. Unfortunately, this data is not out yet, so I cannot talk about data that's not publicly available yet. So I'm going to talk about our earlier NHANES survey. But this data for the future survey years that's going to be based on Serum pools is soon to be publicly available. So I also want to acknowledge to my co-workers in this presentation. So talking about the NHANES. The NHANES is administered by the Center for Disease Control and by two different centers of the CDC. And the NHANES stands for the National Health Nutrition Examination Survey and is run by the National Center for Health Statistics. We're in charge of the specimen collection and also public release of the analytical and questionnaire data. And my center, the National Center for Health and Mental Health, is in charge of the analytical measurements for the NHANES survey. And what NHANES is a statistical representation of the US population's exposures to environmental contaminants, but also nutritional markers. And it's statistically representative based on age, sex, race, ethnicity, and income above or below the poverty level. And it's conducted on a 2-year cycle basis. So for the NHANES, the older NHANES data, now only talking about 3 or 4 unfortunately, we had a 1/3 subset of participants. About 2,000 samples were actually available and analyzed between the age of 12 and 85 years of age. And looking on the race distribution, we have primarily non-Hispanic white participants and smaller amounts of non-Hispanic blacks and Mexican Americans. And the later is actually oversampled in the NHANES to obtain a statistically representative sample for Mexican Americans. But we account for this by using sample weights to make the final estimate representative of the US population as a whole. And for younger and older individual, we had about 12 and 17% that were either less than 20 years of age or over the age of 60. So what I'm going to talk about is the polybrominated difluent ethers. And what we have is 3 different technical products, the penta, octa, and deca mixtures, that now all are being phased out, the deca most recently. And when looking in environmental samples, we see primarily the BD47 and 99 as being the main congeners that bioaccumulate in human samples. From the octa BD mixture, the penta is primarily used in polyurethane foam, and the octa and deca is in hard plastics. And you see that 153 as one of the congeners that are bioaccumulating well in humans. Those are the premier congeners that we're seeing. So basically the penta mixture and the BD153 that are present in both the penta and the octa mixture. Deca BD doesn't really bioaccumulate and has a half-life about 2 weeks in humans. Production figures when they were being used, we have production about 8,000 metric tons per year of the penta, less so of the octa, and the highest volume produced one was a deca BD mixture. And you can see that primarily the penta BD mixture was being used in the United States. So looking on different exposure routes, diet is traditionally considered to be the main exposure route for POPs. But in the case of PBDs, we also have other exposure routes. But another dietary route, of course, is nursing, exposure for the nursing infant. But in the case of PBDs that are present in the indoor environment, we also have dust and dermal contact with flame retardant materials as potential exposure routes. And in the US, dust is the primary route of exposure to humans. But since there are chemicals that are being used or very recently being used, we also have work environment exposures in the electronics industry, manufacturing of polyurethane furniture, but also recycling, carpet layers, we have seen exposures, and primarily for carpet layers is the polyurethane pad that are present on the wall-to-wall carpets that do contain PBDs. So analytical methods, we have gone to great length at CDC to produce high-quality measurements. And what we have for the PBD measurements, the clean room that were built at the CDC to minimize contamination originating from dust or particulate matter in the indoor environment. This room is ALPA filtered, so it's higher grade than HEPA, which is more commonly known. Has a removal efficiency of 99.999% for particles down to 0.12 micrometers. And inside the room, we also have a secondary barrier. There's a biological safety cabinets that is this secondary barrier to prevent particle contamination. And they're being used in all phases of the sample handling. So one thing that was really good for me to sort of calculate and see what actually matters, right? You always need to put things in perspective. So we look on a blank contamination, because we always have a blank, like for BD47. And we have a blank level that's about 5 picogram per blank. But that may sound like a large number in our field, but really it's a very, very, very good blank compared to many other labs, and particularly for the US with the higher indoor levels. If we compare this to indoor dust, we have about 1,000 nanograms of BD47 per gram of dust. So we calculate how much dust contamination we actually have in our blanks. And we take down to be about 4 microgram of dust contamination in our blanks. So basically equivalent of maybe a grain of dust in the sample. But this to a large extent comes from solvents and reagents, and not necessarily from the indoor environments, that we really are controlling for that with our clean room. There's a picture from inside of the clean room, and the main person doing the the sample preparation, Emily Eddingfield. And you can see our large BSC containing automated equipment and another BSC for doing manual manipulation of samples. The workflow procedure is a sample treatment step using an automated liquid-liquid extraction, currently automated on Gills 215 platform, but is being automated now on a TCAN Evo platform that's going to increase our throughput by a factor of 2 to 3 over where we are currently. We can process about 30 samples per day. We're expecting to be able to do 60, maybe 90 samples per day. You have a one-step cleanup to minimize cleanup steps we're doing to again reduce the risk of contamination. So a 2-layered silica-silica sulfuric acid column. And if anyone is interested in details on the methods, we can talk after the seminar. And we finalize it with high-res mass spec analysis of our compounds. We use a thermal instrument. It's a thermal seminar after all. It's a GC-ID-harness instrument. It's a DFS, double focus sector instrument. The condition for PPD analysis is splitless injection using a DB5 HT column. It's a short 50-meter column with a thin stationary phase. And our quantification limits that are maintained over a longer period of time, we can go lower than this, but this is our standard limit that we use. It's 0.5 microgram for all BFRs excepting 209 with a higher limit of detection. And our great hope with chrysosome compression of boosting our sensitivity for 209, I think that's very much doable. But in the case of PBDs, we also have to take into great account the blanks over time. This is 1 year of data of our blanks, showing that we have a very good blank over time of the median of the 5 picogram as mentioned. But in 209, we have a decreasing trend in our blanks over the last year. And we have to do a recertification of our clean room at this time every year. And I wish we didn't have to do that, because that's when our blanks go up. So for quality assurance of the methods, we make sure our recoveries were in acceptable limits. We look on isotopic ratios, as Don talked about. Look at relative retention times. We look at making sure the solution is operating actually at over 10,000 resolution. We confirm for a batch that spiking accuracy. I won't go into that, how that's been done, but before the sample reaches the instrument, we will know the spiking accuracy by doing some procedures we have. We confirm, of course, calibration curves are greater than 0.995 R square, and we also have an additional QA/QC program that apply to the data. And this is actually the abbreviated list that we are looking at in our new data handling system. We're also looking at the ratio between two conveners to see indication of contamination during collection. Looking on CVs over time, this is 1 year data, and we have in general CVs that are in the range of 5%, but they are less than 10 even for compounds without the label. But our general CV is less than 5%. So back to NHANES, we had good detection frequencies for the main congeners that we're looking at, the 28, 47, they are in the 90s, and BD100, 153 also in the 90s, so had good detection frequencies, using a relatively low amount of serum. Statistical methods, we used sampling weights to account for unequal probability of selection non-response, the sampling weights I mentioned. We calculate geometric means for the different categories we're looking at: age, sex, race, ethnicity, the construction year of the primary resident, and native versus foreign born, so high exposures in the US. It's interesting to see what happens when a foreigner moves to this country. We also looked at correlation coefficients. LOD data was substituted in LOD divided square root of 2. We also did regression models where we can calculate the effect from age, continuous variable, and also race, sex. We also include an age squared term to account for non-linear response. We also used calculated least square from the model. We used backward elimination to determine the final variables to include in our final models. We also calculated odds ratios being above the 95th percentile for the same variables. Looking first at BD47, just descriptive statistics, you can see that for BD47 we have a 95th percentile around 150 nanograms per gram of lipids. The highest concentration observed was 2,350, which is a very high concentration of BD47 compared to worldwide. Looking at all the other congeners, we see a median of around 20 and lower levels of many of the other PBDs that we looked at this time. Compared to international levels, we can see that the US levels are much higher than in other countries, compared to the United Kingdom, Sweden and Germany having overall lower levels. You remember the high usage of PBDs in the States. The construction year of the home, in this case not for PBDs, for an older F4 that was phased out in the 70s, we can see that we have a marginal effects of construction year of the home. So people living in newer homes have overall lower levels than people living in older homes where these flame retardants were still being used at the time the house was built. Looking at PBDs, we don't see an effect from that because these are more contemporary compounds that are still very much in our indoor environments. We don't see this effect from the construction of the home. Looking on foreign-borns versus Native Americans, you can see that we have higher levels, again for BD153, the older FR, compared to foreign-borns. When we look on people moving into this country, we actually do not see a statistical difference for BD47, but a marginal difference for BD153, indicating as we move to this country, the level of exposure goes up, and we quickly reach a level that are comparable to Native Americans. Looking again on geometric mean, distributive statistics for several congeners, you can see that we have a general trend of higher levels for the youngest individual, then an increase amongst the older subjects. You see this for all the PBDs. The BB153, the older FR, is different. We see increasing levels with age, indicating that these compounds accumulate in their lifetime, but also that the older subjects were exposed at a time when environmental levels were higher than today. Looking at least square geometric mean, we see this decreasing trend that makes us really start wondering what happens with younger people. Because of course the youngest children would be exposed also to residential dust due to hand-to-mouth behavior. So we could expect to see even higher levels in younger children. And that's where this presentation is going to end. We're looking at also at race. We can see that we had slightly lower levels on Hispanic whites, in this case for BD47. We see similar trends for BD153 with age, so similar pattern as for the other components. In the case of BD153, you see a difference, significant difference on gender, males being higher. It was different from the data that Don showed. That could potentially have to do with work-related exposures that might be less for females. Looking on risk of being above 95th percentile, we can see that in the case of BD47, senior adults were more likely or twice as likely to be above the 95th percentile as compared to younger people. In the case of BD153, we see that males were twice likely to females to be above the 95th percentile, and also that Mexican Americans were 62% less likely than non-Hispanic whites to be above the 95th percentile. So ending on NHANES, and that's just on NHANES. You can see the highest level observed was 3,600 for total PBD in one single subject. We need to do further studies to see if levels started to decline or not in the US, and that's forthcoming. We also need to give special attention to children's exposure in certain occupational and also in certain occupational settings that may have an increased risk of exposures. And that's work that has been done, but I won't go into that. So on children, to be able to complement the NHANES survey, what we wanted to do is look on younger children. And we had an opportunity to have collaboration with Untitled Chapter at the University of Texas to look on younger children. And it's more of a convenient sample, so it's not representative of the US population. But our hypothesis was that PBDs and other contaminants may be higher in children, and also that the NHANES survey is limited to age 12, due primarily to availability of serum. We have serum from children going down to age 6, but there's too small amount of serum actually available to do the PBD measurements. And also PBD in the indoor environment could be a likely contributing factor to the overall exposure for children. And also that children are more exposed to from hand-to-mouth behavior than adults. So the study design for a study was to sample children from a medical center in Dallas, Texas. The sample collected in end of 2009. The sample originally collected for pathology testing, and it's not known to as samples were collected for routine study or if the children were receiving treatment for an ailment. And that could potentially bias our data, since a sick child may be less movable than a healthy child. But it's not known to us if you have this effect or not in our study. It's a convenient sample with no information on the individuals. The only thing we have available is the sex, the date of birth, and the date of the sample collection, from which we could calculate the age of the child at sample collection. We have 300 samples available, probably 25 samples per year. But a good detection frequency for the PBDs, despite low volumes, 96% for 47, and good rates for the other compounds, using a median sample size of 1 gram, which is a very low amount of serum for this kind of work. Also had a variable amount of serum, 95% that was 0.39 gram, and obviously the children of young age are primarily ones with low volume. But we have done work to make sure that we don't have a bias from sample size in our work. I won't go into that either. Looking at BD47 here, stratifying our sample in 1 year increments, we can see that we're increasing levels as we would suspect to have. Starting at levels a little bit lower than in NHANES, but this could also be the dilution in a growing body size for a child less than 1 year of age from delivery. We reach higher levels over 1 year and a maximum around 4 to 6 years of age in the case of BD47. For BD153, we see a shift towards slightly older ages than for the BD47. And comparing this data to NHANES, and observe here that I'm using 2 year age brackets instead of 1 year as in the previous slide. And we can see that we have similar levels for 20 plus to the 0.0 to 2 years, indicating that at birth the level in the child is similar to its mother. We then see increasing levels up to 4 to 6 years of age in the case of BD47. For BD153, we have an apex between 4 and 8 years of age, and similar levels again to the NHANES survey. To the remarks, the serum concentration PDs we have assessed in children less than 13 years of age. The levels of PBDs peak between 4 and 8 years of age, 4 to 6 for BD47, and 4 to 8 years of age for BD153. And this difference could potentially be related to different half-life of the compounds. We observe high levels in children that potentially could be explained by dust ingestion. And we need to give further attention to children's exposure in the future. And with that, I would like to thank you for your attention.